Hi, my name is Grania. I'm one of the equipment consultants here at Burton's, and in this video we'll be discussing the M880 capnograph and SPO2 machine. So as we said, it monitors capnography, which also offers then the ability to monitor respiratory rate through our sample line and our capnograph module. And we also have the option of monitoring SPO2, which will also provide us with a pulse rate. So the monitor is designed for anaesthetized patients or sedated. We can use the sample line with our airway adapter for patients that are intubated, and you can use a nasal prongs if you have a patient that's sedated and want to monitor respiratory rate that way. So it's a handy device to use for anaesthetized patients and will give us a lot of information based off of the two probes. So overall we've got our two ports here, our SPO2 port and our CO2. It's really important that we use a filter for this, and this is basically to prevent water vapor from getting into the machine. So it clicks into place with the two slots here and twists, and that's fixed in position, and then we just attach our sample line. So this then, this portion of the sample line will then attach to your airway connector. For our smaller patients, we can use low dead space adapters. They are just to prevent increased dead space. So this portion is fine for larger dogs, medium to large dogs, and then ideally for smaller ET tubes, therefore smaller patients, we'd use the low dead space adapter with this portion of the machine. So the other aspect just to touch on is the exhaust port, and this is basically as the machine pulls in the sample of the breath from the patient, that we use that portion of the breath to analyse the CO2, but any trace elements of inhalational gas is removed to your scavenging system so that we're not essentially polluting room air with trace elements of sevoflurane or isoflurane, depending on what you're using. That's not necessary to use if you're not using inhalational agent. So if you have a patient on total intravenous anaesthesia but want to use capnograph, use the capnograph function, then this won't be required. Otherwise, if you attach it to your exhaust kit like so, and then this attaches to your scavenging system. So that's kind of a brief overview. What we'll talk about in the video essentially will be how to set it up, how to set your limits, and how to kind of troubleshoot and how to apply it as best you can to get the best results, so that you can interpret it accurately and you're getting accurate results for your patients. So we have our on button here, which we just hold on. The screen itself is gravity fed to either present horizontally or vertically, depending on how you hold the machine, and it will stand up of its own accord so that you can monitor it as you go. So one of the advantages of the M880 obviously is its portability. It's really small, so if you're moving patients a lot or if they're in the recovery phase, it's obviously small and handheld, so it can be used kind of kennel side as you need it. So depending on how we position the screen will show different aspects, and we have our three touchscreen buttons at the bottom. I can alter through my screen by pressing this button at the bottom, and that will present differently. To give the maximum amount of information, it's handier to have it held horizontally, and then that gives us more information all on the same screen. So now that we've turned our machine on, we've connected our filter, our sample line and our SPO2 probe. The first thing that we'll want to do is select our species. So this machine can monitor dogs, cats and horses, and the selection of the species will alter the alarms that the machine will give depending on the species. So typically in a small animal setting we're going to monitor on our cats and dogs. If you're using this on a species that is outside of those, then ideally just select the closest physiological parameters. So for example, a rabbit is probably going to have a similar heart rate to a cat compared to a canine. So if hopefully we can see the screen here, and we have animal info, and very simply then we're going to change the type from dog to cat, for example, or tap through to horse and back to dog. We have an ID number here where we can insert our practice management ID if you want to data export the information afterwards, or typically it is a kind of plug and play, so essentially can be used on any patient without inserting an ID. So now that I've selected my correct patient, I'm just going to OK and then go back to the main screen. So when I have the machine held in this way, the gravity is holding it to, that it's going to present in this format, and then if we turn it to the side, we get all of the information passing through. So just for this, I'll have it standing. So when we have the patient set up, we want to make sure that the machine has been turned on for at least 2 minutes, and that essentially is warming up the CO2 module internally to allow it to accurately measure as soon as we apply. So ideally, this machine is turned on 2 minutes prior to use, before being connected to our patient. So once we have that set up, essentially everything else is ready to go. We'll attach and we'll instantly get a capnograph form, and we'll also can attach our SPO2 probe directly as well. We can see here we have our CO2, which is going to be our capnograph. So capnometry is referring to the number that we get, which is our ET CO2, and capnography is referring to the graphical representation of the patient's ventilation waveform. So we'll have that at the top. We have ET CO2, respiratory rate, and importantly we have fractional inspired CO2. So very briefly, end-tidal CO2 is measuring the percentage of carbon dioxide in a patient's exhaled breath, and fractional inspired is measuring the level of CO2 in the fresh gas flow or the inhaled portion of the patient's breathing. We can have issues with high fractional inspired, so it's important to try and monitor that. For example, exhausted soda lime, where the CO2 is no longer being absorbed by the soda lime, that fractional inspired CO2 will come up, and then that will be represented on our waveform with a non-return to baseline. So we'll get a graph that doesn't return to the zero baseline and with an increased fractional inspired. So in combination with the graph, my FI CO2 and ET CO2, I'll get a very good picture of how that patient is ventilating, and then that will allow me to instigate whatever clinical treatment is required. Obviously, respiratory rate and the graph itself is very helpful to assess the patient's depth, so we get a lot of information from that itself. We can alter different parts of the CO2 and the graph itself. Currently it's set to 61 millimeters of mercury, so we can raise that higher to monitor higher levels of CO2. However, typically we always want our CO2 to be lower than 61, so it's not often more helpful to have a smaller graph with higher numbers. So it will just change, alter it, and we'll go through that in a minute, how your graph looks on the screen and where it rises and falls as such. So if we follow down, then we've also got our what's called our pleth trace, and then we've got our SPO2. So our pleth trace is referring to the contact that the probe has with our patient, and then we will get our SPO2 percentage. So this SPO2 probe is monitoring the percentage of hemoglobin that is bound with oxygen. And we can have a patient that's desaturating, i.e. their hemoglobin is not bound with oxygen. So ideally we always want that number over 95, and you can see throughout all of these different settings we have little numbers on the inside here, and that's referring to your alarm settings. So at the moment I have this set to 90, but we can go in and alter that as required. And we have different settings here, and again we spoke about this earlier, but the alarm settings are pertaining to the species. So for example, the heart rate alarm or the pulse rate alarm will differ for a canine patient to a feline. So in terms of the alarms that the machine will present to us, we have two forms of alarms. One is audible and one is visual. In terms of audible and visual, they'll be tied together. So the highest form of alarm will flash red and will make the loudest noise and the longest noise. The medium alarms will flash yellow and have a mid-tone, and then the lowest alarm will have a solid yellow, like we can see here hopefully, and will make the lowest tone available. So it's visually up here we'll get the alarm, and there's three different types of alarms that we can get. The first one, which is the most important and what we'll respond to quickest, will be the physiological alarm. So this is essentially the machine telling you that there is an issue with some of the parameters that we're measuring that we have set the alarms for, i.e. the heart rate is higher than we would expect or want, or the respiratory rate is higher or lower, etc. So that's the physiological alarm, and that's referring to presumably your patient. And then we have a technical alarm, so where the machine is not functioning as it should due to a technicality, and we have that error at the moment, for example SPO2 sensor off. So that's not a physiological issue with our patient, it's actually a technical issue because the SPO2 probe isn't measuring tissue within it. And then finally we have what's called a prompt or a message, which is just something telling you that there is something that needs attention at some point, for example, like the battery. So in terms of our alarm settings, we want to make sure that we're always responding to the alarms when the alarms are telling us something that we need to know. So we want to make sure that we don't become complacent with the alarm settings, and if it's beeping for a reason. So to maximize that, we want to edit our alarms for our patients, and it will be very patient dependent. We spoke a little bit about how it varies between species, but it will also vary between a Great Dane compared to a Chihuahua. They're probably going to have different heart rates, so we'll want to alter it as a result. So to do that, we're going to go into the menu button and essentially go in. We've got our options of SPO2, CO2, trend review, and the system. So anywhere that I'm changing my alarms will be on this screen. So for example, my upward limit of my pulse rate for this particular patient is 160, and I'm just going to alter that, say for example, to 130. So once I've changed my setting, I'll just go to OK, and then if I go back to the screen, my parameters here are set different so that my new alarm is set and within there. So if ever in doubt as to what the alarm is setting to, it is just a case of checking these little numbers to the side. We'll get more information there. So we've got all this information here about what my new pulse rate is, for example, 130, and on the lower end is 70. So for example, a lot of patients that receive medetomidine will have a lower heart rate than 70, so it's worth going in and changing that for those patients, just so that it's not constantly alarming and then we become complacent to the alarm. So everything really can be edited as much as you like. We can go in here and go into CO2 setup, and similarly we can alter anything that we need to. So we can alter the higher end tidal CO2, lower end tidal CO2, and we can also alter respiratory rate. So the other option that we have with the machine is to alter the sweep, and that's referring to, or the speed, that's referring to the representation of the graph compared with time. So for example, if I want to see more in a smaller screen, I can change that, or if I want to see less and have more detail, I can also alter that within these settings. So everything that you would have on a, every alterable setting that you have on a multi-parameter monitor, you can also alter within here. And it's just important to note that if I'm not using CO2, that I plug out my filter and my sample line, the CO2 is actively pulling from my patient's breath. So when I'm not using it, to preserve the internal module of the CO2, I'm better to remove this so that it's not pulling and actively working the module, and preserve the life of the module. So if, for example, you're in recovery, your patient's extubated, and you just want to use the SPO2 probe, it's worth disconnecting that and placing it back in the box to preserve the life of the module. In terms of practical use, we spoke already about our capnograph and how we would use it with our airway adapter, and how we'd use low dead space adapters for smaller patients. We often get a lot of questions about how to maximize the use of our SPO2 probe. We can see here that we have an infrared light, and then we've got our receiver. So essentially we're trying to put tissue in between here to allow the machine to monitor the hemoglobin and the saturation of that hemoglobin. So to try and maximize that in terms of locations, the ideal location for this probe is the tongue. Ideally we want to use it in the center of the tongue to maximize its contact with tissue. The important thing is to regularly move the probe away from that tissue so that we're not causing any trauma underneath for prolonged surgeries or anesthetics. And ideally we always have the infrared light coming from below, so we always want our receiver facing downwards, because that receiver can be influenced by other lighting. So if we have it facing to the floor, we're not going to get any lighting impact from below, and that's just to try and improve our contact. So we often get people mentioning that it's difficult to get a reading sometimes on our patients, and when we're using medetomidine, we often have a patient that is peripherally vasoconstricted, and therefore we have less blood to monitor. So ideally we want to try and use the clip that is the least amount of force on our patient. So included in the machine is a smaller probe, which will put less pressure on tissue, and this is particularly important for patients, for example, that have received medetomidine and have peripherally vasoconstricted and therefore have less blood already. So if you imagine that this probe is causing a clamping action on tissue and essentially is blanching that tissue further away and reducing blood flow further. So ideally we want tissue that is nice and thick and not overly pressured by the probe itself. And if you feel that that's happening, you can obviously swap to the smaller probe that has less force applied. So it can also be used on other areas. So we have, ideally the tongue is used as the ideal location. However, some people don't like to use it for dentals because it gets in the way, or if they're doing facial surgery of sorts. So it can also be used on the toes, on the prepuce, on the vulva, any tissue really that is able to go in between. It is better on non-pigmented skin. So ideally if, for example, a cat has a white paw with white toe pads, we would use that over choosing it over like a black paw or black toe pads. So it is actually challenging in some cases as well if we've got pigmented tongues, and so something like a chow or a Shar-Pei is also a bit of a challenge, but most often you can find hopefully in the most non-pigmented part of their tongue, for example, and it will hopefully work in that regard. In terms of troubleshooting the device, if we split it up into issues with capnography and issues with SPO2, we touched on it in the previous section, but essentially the most people struggle with not getting a reading, and it's often with patients that have maybe an altered cardiovascular status or peripheral vasoconstriction, and ideally we'll just move this to different locations to try and optimize the reading. We discussed obviously having the receptacle facing down. Sometimes people will use a damp swab to try and essentially cushion the tissue to prevent the constricting aspect of the clamp itself, and we can obviously swap to our different probe to prevent further clamping. In terms of CO2, the main issue that we'll have is what is represented on the screen. So if we have a patient that has a low end tidal CO2, the first thing that we might think of is that we've got a leak somewhere. So leaks can form at any point in the system. Very typically a crack will form in the sample line just here, as over time it starts to wear. The first thing that we think of typically if we have a low end tidal CO2 is that there's a leak in the ET tube cuff. So a low ET CO2 with an abnormal trace is our first indicator that there's a leak in the ET tube, and that's where we'd obviously use our cuff inflator to reassess that ET tube and make sure there's no leak anywhere. The adapters can also disconnect from the ET tube, so we want to make sure they're in nice and tight, and certainly that we have this tied nice and tight to the adapter itself. So that's most common. The most common issue is a low end tidal, which is indicating a leak. A leak can also form at this portion here, just as a bend forms over time. When we have unusual graphs or unusual end tidal numbers, that can indicate that there's an issue with the filter, and that's where the filter needs to be replaced. High end tidal or high fractional inspired CO2 would indicate that there's an issue either with a low fresh gas flow or a exhausted soda lime, or for example a blocked scavenging valve as options for that increased FiCO2. We typically don't get issues with high CO2 as a result of any issues with the tubing. Potentially low end tidal CO2 could also mean that we have issues with the sample line becoming saturated with water vapor. So the pump of the machine is actively pulling from the patient's breath, and it's important to note that as it pulls, it's pulling not only CO2, a certain degree of oxygen, our inhalational agent as we discussed earlier, but also the water vapor that the patient expires. So whilst it's pulling, we want to try and prevent water vapor from entering the machine as much as possible. So as a result, I always want my sample line to be attached uppermost rather than attached down at the bottom, because water vapor will obviously flow with gravity. You still will get a degree of water being being absorbed by the machine because of the suction pump built in, but we just want to try and deter as much water as possible from getting to the machine and causing damage to the internal module. So in terms of maintenance, cleaning and consumables, as part of the initial order included is a few of these filters. So we can see them here, and we have one attached to the machine already. So the aim of this filter is to prevent water vapor from getting to the machine, which can damage the internal module inside. It's really subjective as to when these get changed, because a practice using this can have 600 surgeries in 1 month and another practice can have 200 surgeries. To try and preserve the life of the filter, we'll always want to disconnect it, which will stop pulling air through it, and we always want to disconnect our sample tube as well. So to try and preserve this, we'll disconnect our sample tube and try and hang it down so that we get the water vapor to drip with gravity. Typically people will do that at the end of the day to try and preserve the life. The sample tubes, these need to be replaced as and when. Most often they either become blocked, so we're not getting a CO2 reading, or a crack forms and we start getting really low end tidal CO2. So it's really important to have a number of these on site. A lot of the time they can get stepped on and cracks will form, so if you don't have an adequate sample tube, you won't be able to use the capnography portion of the machine. The other item included is your airway adapter. These typically can be used and cleaned with your ET tubes and cleaned with the same process that you use for those. The device has an IPX1 rating, which means it's protected against condensation and water droplets. So we really want to minimize the use of lots and lots of fluid on the machine. So it can be cleaned with a hospital grade detergent, used at the lowest concentration and used with like a damp cloth rather than excessive use of liquid, and that's for the device itself, and we want to unplug these the two probes and make sure that we keep the ports free of any fluid. In terms of cleaning the sensor itself, it's recommended that we use 70% isopropyl alcohol on a lint-free cloth to clean both the infrared light and the receiver. Very often you'll get blood into the probes itself if the patient's having, let's say for example, a dental surgery or facial surgery, and these come away, as you can see from here, and they can be swapped out. So then you can use let's say a harsher cleaning agent like your hospital grade detergent to remove any debris or blood that gets inside the probes themselves. But it's really important to separate the sensor from the probe so that you can clean them adequately with the different agents that you need to use for them. So in terms of maintenance, the machine should run and operate as and when it's needed. It can have a yearly service to just make sure that the calibration is okay. And throughout its use, you might find that it will zero. So essentially the internal capnograph module needs to recalibrate over time, and that zeroing might look like a flat line of your respiratory rate or your capnograph, and it's just the machine recalibrating, and it will only be for a certain length of time and then will represent your patient's breath again. So that will do that every so often built into the system, and then obviously it can go for its yearly service. If you have a scenario where the CO2 module is not working adequately and we've changed the sample line and changed the filter, beyond that is a case of going to the repair centre here at Burton's for an inspection to hopefully repair the internal module that might be damaged. So that brings us to the end of our M880 video. Thank you very much for watching. Obviously your device will come with a user manual for more information, and there's lots of more information, articles, videos on the Burton's website as well.